Evening, everyone. So for today's lecture, we're going to discuss the upper GI bleeding. Okay. We'll go through the most common causes of upper GI bleeding and the management of these cases. However, the management is not the area of focus of this presentation. Okay. So, since we're talking about the upper GI bleeding, we have to define or differentiate between upper GI and lower GI bleeding. So, what's the anatomical landmark that decides above that landmark there would be upper GI bleeding, or lower than that there would be lower GI bleeding? Ligamental types, and what's it's dividing actually. So it's dividing the intestines, above that ligament that would be the duodenum, and lower than that there would be the jejunum and ileum. So any fluids or any piece in the duodenum which includes upper GI bleeding signs, and in the jejunum and ileum you would expect a lower GI bleeding. Okay. The sources for the upper GI bleeding, it could be anything from anywhere from the mouth till the duodenum. Okay, so the sources over here, it says esophagus, stomach, duodenum, and the structures that are the structures that have an opening into the duodenum, like the liver, biliary system, and pancreas, since they are all voiding in the ampulla of Vater. Okay, and the ampulla of Vater is located second part of the duodenum. Okay. So the most common cause of upper GI bleeding is peptic ulcer disease, and I think we've talked about the peptic ulcer disease in previous lectures, right? But before we talk about the causes, let's discuss the signs. So, what do you mean by upper GI bleeding? So we define that based on the anatomical landmark, but what would you expect? Melanin. Melanin. So what's melanin? So melena is dark stool. Okay. What else? Hematemesis. What's hematemesis? So vomiting of fresh blood. What else? Anemia. Okay. Iron deficiency anemia. It could be there in upper and lower GI bleed. What else? Hematochezia. And what's hematochezia? So passing of fresh blood per anus. Okay. So when would you see that in the upper GI bleeding? Yes, exactly. So you would expect this in lower GI bleeding. However, if the upper GI bleeding was massive and uncontrollable, then instead of having melena, you would see a fresh blood per rectum. Okay. All right. So the most common cause, it's peptic ulcer disease or peptic disorder, and it contains underneath that the duodenal ulcers, gastric ulcers, and also since we're talking about peptic disorders, we're referring to any entity that's caused by like the gastric hyperacidity. So there would be also reflux esophagitis, gastritis. The gastritis, it could be also due to other reasons like stress ulcers, alcohol intake, or even NSAIDs. okay, and also the duodenitis. The second most common would be like bleeding due to portal hypertension, okay, and the portal hypertension is not the thing that's causing the bleeding directly. It's the complications of the portal hypertension, as we will see later. So, as a complication of the portal hypertension, as you know, guys, there are like collateral circulation that's running between the systemic circulation and the portal system. Okay, so since we're having a high pressure in the portal system, these collaterals will be dilated, and then it would be functional. So these communications would be engorged. Okay, and as a result of that, there would be submucosal veins which are enlarged, and then these are the ones that are causing the bleeding. Okay, so the manifestations of that would be esophageal varices. And do you know like what's varices? Dilated submucosal veins. Okay, so esophageal varices are there, the gastric varices, and also there is another entity which is called the portal hypertension gastropathy. Okay, so what's gastropathy? A disease in the GI system. More specific?
Erosive, like very light erosive disease in the GI.
Okay, so there is a difference between like ulcers and gastropathy. So they are all related to the mucosal injury. However, the ulcers is due to like inflammatory process or even direct like acidic injury. Gastropathy meaning is that there would be a mucosal injury, but related to the like vascular anomalies, and in this case we're talking about the gastric varices. So the mucosal surface would be affected, and it would manifest as a watermelon stomach. Okay, so this is the image of the watermelon stomach. So if you go into the endoscopy, this is the gastroesophageal junction. So you would see like there is like erosive or atrophic kind of mucosal injury. Okay, and it's patchy, so there would be normal mucosal appearance and this type of mucosal injury. So this is what we call gastropathy. Okay, and it's seen only in like portal hypertension. So these are another image. Okay, so next we have other causes of upper GI bleeding, but usually they are rare compared to the peptic ulcer disease and the bleeding due to the varices. Okay, first we have the Mallory Weiss tear, and do you guys know what's that? Longitudinal ulceration of the mucosa, and that's due to, yes, so retching, which is like the forceful vomiting. Usually what we refer to as retching is that like it's the like forceful vomiting against a closed gastroesophageal junction. Okay, so that effect would cause the longitudinal tears, which is the Mallory Weiss tear. Also, we have a bleeding due to any neoplastic source, which is there in the esophagus, stomach, or duodenum. We have also congenital anomalies like the Dwellofoy lesion. So all of these will be later discussed in details. Aortoduodenal fistula, it's seen in those who underwent like graft surgeries for aorta. Okay. Angiodysplasia, this is usually seen in elderly and those who have renal or cardiac failure. Esophageal sources like esophagitis, as we discussed earlier, Crohn's disease, it's the inflammatory bowel disease. Usually it's causing lower GI bleeding. However, it can affect the gut anywhere from the mouth to the anus, right? So it can cause also a source of upper GI bleeding. Biliary source, and we call it hemobilia. Hemo, so it refers to blood, and bilia referring to the biliary tree. Drugs, as we said, the NSAIDs, it can cause also like upper GI bleed. Pancreatic source and duodenal diverticulum. So duodenal diverticulum we've already discussed in the previous lecture. Okay. So usually, whenever we're talking about upper GI bleeding, most of the time, and the common cases, usually they stop spontaneously. Okay. However, there are certain cases which causes like massive upper GI bleeding. Okay. And these would attribute to the overall mortality, which is like from 5 to 10%. However, if the source of bleeding is like continuous and the bleeding is recurrent, the mortality can go up to 40%. And the mortality is linked to the degree of hemorrhage and the coexisting medical conditions like Crohn's disease and angiodysplasia and all of that. And also, like since we're talking about the like the medical conditions and the mortality, if you guys think about like the massive GI bleeding, what would be the consequence of that? Shock. So hypertension and shock. Those who would suffer from the hypertension and shock, can you think about any like population? Elderly, excellent. Because most of the time they're going to have cardiac issues. Okay, and as a result of that, they're not going to tolerate like the like a massive drop in blood pressure. Even if we transfuse these patients, there would be like an overload to the heart. So the preload would be very increased. And as a result of that, it can worsen the heart failure. Okay. In addition, you can also think of those who have chronic renal disease. Okay. Because like any hypertensive crisis can cause also renal failure as a result of the what we call it the pre-renal causes, which is like the most common one is the hypertension, and we call it pre-renal azotemia. Okay. As we said, like the majority of cases would stop spontaneously. The age is an important risk factor because of the medical conditions. And 50% of those who would suffer, they are above the age of 60. Surgery is rarely required to stop the bleeding. Usually, the management would be medical with PPIs, sometimes even octreotide for hypertension, especially, and viruses. And like if medical therapy has failed and even like the bleeding did not stop spontaneously, then usually the management would involve endoscopic therapy. Okay, and when with endoscopic therapy, there would be either injection directly through the bleeding vessel, like if the bleeding is active, or if we find that there would be varices, then the management could be by band ligation. Okay, so we go and like apply bands all over these varices, and then they would like undergo ischemic changes, and they would fall down like with stool. Okay, so again, peptic ulcer disease is the most common cause, and we've addressed that in previous lectures. Usually the most common presentation or the most common complication of peptic ulcer is what? Is it? It's the bleeding, yes. So you have to like put into consideration the following. So bleeding is more common than okay, and the most lethal consequences of the peptic ulcer, especially if it was in the lesser curvature of the stomach, it would be due to bleeding. Okay, preparation can be dangerous as well, but it wouldn't be like as lethal as the bleeding. Okay. And why did we say that it's more lethal if the peptic ulcer was in the lesser curvature? Yes. So if there is an ulcer in the lesser curvature, then the left gastric artery would be involved, and the left gastric artery is a major artery, a big artery, right? So stopping the bleeding in the left gastric artery would be difficult sometimes. So there are certain factors that are associated with poor outcome when talking with the peptic ulcer disease, especially if the rate of the bleeding and the volume was voluminous to start with, because like the rate of bleeding, like if it was, for example, 1 liter per day, would be different than 1 liter per hour. Okay, even if the outcome was loss of one liter for the whole day. Okay, so initially the severity and the magnitude of the volume would consider the outcome. Okay, persistent hemorrhage. So as we said, if the bleeding did not stop, and if it's like stopping and recurring for another time, the advanced age because of the comorbidities and coagulopathies. So those who have liver disorders, which are affecting the production of the coagulation factors, would also suffer, because we have bleeding time and elevated PT and APTT. So always when we consider the management for such patients, we ask about 3 things. Any previous cardiac problems, what's like if there is any disease to the kidneys, because these are the major comorbidities that we need to consider. And we have to consider also the liver disorders. And once we investigate, we have to see the kidney functions and the APTT, the PT, and the bleeding time. Okay. So so these are the risk classification for the peptic ulcer disease when we are considering the bleeding. So the acronym is BLEED, and the ongoing bleeding, this is the first one. The low systolic blood pressure, because this will determine the shock. Elevated PT, as we said about coagulopathies. Altered mental status, which is would decide also the shock if the patient was unconscious or not. And if there is any unstable comorbidities. So based on the risk factors, there would be also increased risk of hospitalization, increased risk of recurrent bleeding, and if there is a massive bleed, then we have to consider surgical intervention. And of course, there would be an increase in mortality. So as we said about these comorbidities, so acute renal failure, respiratory failure, especially if it was associated with heart failure, chronic liver disease and cirrhosis, because they would cause abnormal liver profile and coagulation profile as well, and congestive heart failure. So this is the prognosis for a certain factors. Okay, you don't have to memorize these factors, but keep in mind that, like with older ages, the mortality will increase. If there is a drop in the systolic blood pressure, then also the mortality will increase. In this case, the NG tube aspiration. So as part of the management, we have to keep the patient NPO, and we insert also nasogastric tube. The function of the nasogastric tube is to aspirate or suction the content of the stomach. Okay, and as the name indicates, where is the last destination of this tube? The stomach. So if there is if there is nothing that comes or no blood that comes with the NG tube, does that signify that there is no upper GI bleed? No. Why? Exactly. So because we left the duodenum uncovered. We have also one of the signs of the upper GI bleeding is the coffee ground emesis. Okay, but usually the coffee ground emesis is of less less riskier than the fresh blood. Why is that? Because the coffee ground emesis indicates that the bleeding has stopped, and what's remaining, the remnants of blood would be digested. Okay, unlike the fresh red blood. The fresh red blood indicates that there is an active bleed. And also, one thing to consider is the units of blood transfusions, because this will give you an indication of the volume of blood loss. Okay. So what determines the risk of rebleeding is the appearance of the ulcers in endoscopy. Okay. And there is a classification for that, and also the rebleeding rate is increasing also with the ulcer size. So this is the classification for the appearance of the ulcers on endoscopy. The most benign thing is the clean ulcer base, and this indicates that the bleeding source has healed and there is no active bleeding. Okay, pigmented spots, which is also there could be the bleeding has stopped already, because the next one is an adherent clot. Okay, and if there is a clot, this would indicate that the bleeding has just stopped. Okay. And the next one would be the visible vessel and the active bleeding. Okay. So since we're going from a clean base into an active bleeding, the risk of rebleeding will increase. Okay, because even with the pigmented spot or adherent clot, the clot could be removed from the ulcer base. Okay, and if the clot has been removed, then the bleeding could start again. So this is another classification of the appearance of the peptic ulcer on the endoscopy, and it takes into consideration this classification. However, it's from the worse into the better. Okay, so they start with the active bleeding, and they end up with the ecleal muscle base. So these are the images of the of this classification, which is called the Forest classification. So first, they start with the active bleeding, and then the lesser degree would be the oozing of blood. Okay, the lesser degree would be the visible the visible blood vessel, and then the adherent clot, and then the pigmented spot, and then the clean ulcer. So we're done with the peptic ulcer disease. The next most common cause of bleeding would be the like varices because of the portal hypertension. Okay, and they account for like 30 to 35% of all deaths in patients with portal hypertension. Okay, usually, like, how do we decide the portal hypertension? How to measure it?
You check the liver function.
Liver function. Okay. Yes. We call it the hepatic venous pressure gradient. HB, hepatic HVBP. So PV. Oh, okay. Okay. So what's the gradient of the like when to consider the portal hypertension? What's the number?
6.
Above 10. Okay. And then above 12, we would think of like varices formation. Okay. All right. So 90% of all cirrhotic patients will develop esophageal varices, and then 30% of those will develop upper GI bleeding. So not all cases of esophageal varices we will find a bleeder. The mortality goes up to 25% with each episode of bleeding. The rebleeding is in 70% of patients. So this is the definition of the varices, which are the dilated submucosal veins that communicate with the portocollateral circulation and the systemic venous system. Usually, what are the portosystemic anastomotic sites? So first of all, we have the esophagus. Where in the esophagus?
The lower
The lower third of the esophagus. And what else?
abdominal wall.
Abdominal wall,
Yeah, the conductor, and then the anal.
which is the periumbilical.
Yeah.
Okay.
And then the anal.
The anal canal, which is like the upper half of the anal canal. What else?
Kidneys.
The kidneys. What else? So let's think about the GI. So we have the lower third of the esophagus, the stomach. There could be like the cardia of the stomach would be involved. The spleen, okay, because also it can affect the splenic vein, and as a result of that, there would be varices in the stomach, varices in the esophagus, and splenomegaly. Okay, and then the anal canal, which is the like the upper half of it, the periumbilical area as well. Okay. Okay, so they may vary in size from small into large, like from millimeters into centimeters. And they are more common in the distal esophagus. The gastric varices along the cardia and high greater curvature, since we're talking about the splenic vessels. So the cardia and the greater curvature, the high greater curvature. So these are the sites. We can see that since there's going to be like a portal hypertension, then the pressure would go into the collaterals, the communications with the systemic venous system. So it can go to the esophagus and cause esophageal varices. It can go into the splenic vein and cause also splenomegaly. It can go into the inferior mesenteric vein and causes the hemorrhoids and the anal canal. So these are the pathogenesis of the portal hypertension. Usually you should cover that in the physiology lectures, right? So did you cover that already? Okay. So as a result of the portal hypertension increase, there would be an increase in pressure in the portal vein. And then the splenic, there would be a splenic vasodilation, okay? And as a result of that, there would be a systemic hypertension and effective hypovolemia. And due to this hypertension and hypovolemia, there would be an increase in norepinephrine and vasopressins in order to do a vasoconstriction systematically, okay? But this adaptation would worsen the case of portal hypertension. And as a result of that, there would be an increase in the flow of the portosystemic shunts. And also there would be also the sodium and water retention and the consequences of that. So this is a summary of the portal hypertension. So the risk of hemorrhage with portal hypertension increases with the size of the varices, and there's also a classification system for the portal hypertension, and if there is the active cause of the portal hypertension and the cirrhosis, which is the alcohol intake, because alcohol intake can injure these varices directly and cause the bleeding of these varices. So primary prevention, initial treatment of acute variceal hemorrhage, and definitive management of variceal hemorrhage will be discussed in the management of portal hypertension. But usually the management is not an area of focus. So these are another images of the portosystemic shunts and the varices that develop. So we can see that there would be engorged veins in the lower esophagus. There would be also affecting the lesser curvature, because the left gastric vein would be directly affected. And you can see that the engorged vessel posterior to the stomach, which is the splenic vein, is also engorged. And as a result of that, it would affect the short gastric vessels of the cardia and the esophagus. And also the greater curvature would be affected, and this vein is called gastroepiploid vein. Okay. And this is the appearance on the endoscopy. These are other images. So this is the appearance of the varices in the endoscopy. So as we said, it's a submucosal enlargement of the veins. So it doesn't appear directly on the mucosa, but you can see that there is a tortuous vessel going beneath the mucosa. So this is the band ligation of the esophageal varices as a management of the bleeding varices. So if there is a stomach varices, it would appear like that in the endoscopy. So the next cause would be the Mallory waist tear. So as we said, it's a longitudinal mucosal and submucosal tears as a result of the retching or the forceful vomiting against a functional the gastroesophageal sphincter. Okay. and it appears on the endoscopy as longitudinal tears. Okay. The risk factors would be like even if there would be like a concomitant hiatal hernia. Okay. However, the bleeding because of the hiatal hernia most probably due to peptic ulcer disease. Okay. But the presence of the hiatal hernia would be considered as a risk factor for that. Okay. So associated risk factors would be like alcoholism, especially like if they give you a scenario in which they mention that there is a young patient who like binge drank, and after that night they had like several episodes of vomiting, and then they present with the upper GI bleeding. Okay, so the first thing that you need to consider is what? Miller-Lewis. Okay. Also, other risk factors could be NSAIDs, portal hypertension, and epileptic patients. This is very important. It's more common in men, and especially over the age of 60. It accounts for 5 to 10% of patients with upper GI bleeding. It's considered a rare cause. However, it's a very important area for examinations, especially even in step 1, they like to ask about it. So the bleeding would stop spontaneously as peptic ulcer diseases and the bleeding from the varices. So these are the endoscopic images of the Miller-Lewis, and you can appreciate that there is a tear in the mucosa and the submucosa. And these are the longitudinal tears that we talked about. So this is another slide in the pathophysiology. So it's longitudinal. It's 1 to 3 centimeters in length. The location would be the lesser curvature of the stomach, the cardia, even the gastroesophageal junction can be involved, and the stomach. The stomach, where exactly? The distal part of the stomach. So the risk is increasing as long as like the area involved would be around the gastroesophageal junction. Because of this this reason, because always there would be a pressure against the lower esophageal sphincter. Okay, and this is what's causing the tear during the vomiting. Okay, so as we said, it involves the mucosa and the submucosa, and only 10% of these cases would bleed. And it could be also the tear itself could also be complicated with infection and inflammation. So these tears eventually can lead to ulcer development, okay, and esophagitis or even mediastinitis. So as part of the management for such cases, we also give PPIs in order to stop the acid production and prevent the development of ulcer formation. So this is the principle of the management. So you always have to consider the history, especially like if the patient is epileptic or they're drinking alcohol. Okay. As we said, bleeding would stop spontaneously. If they bleed, they do not rebleed. Okay, because like like only 10% of these cases would bleed to start with. And if they bleed, it would be leading to a massive bleeding. Okay. The initial management would be fluid resuscitation, and if there is any coagulopathy, we need to correct that. The NG tube for aspiration and to keep the patient NPO. And we have to measure the outputs, which is through what? Foley's catheter. Okay, Foley's catheter. input and output charge. So we have to measure the intake of the fluids of the patients and the output, which is the urine production. Okay, so this would also give you like another clue about the hypovolemia and the amount of bleeding the patient is having, because with the less output production, there would be a hypovolemia. Okay. So we need also to stop alcohol and prevent the occurrence of the vomiting by antiemetics. Okay, and as we said, we give the patient PPIs, and like if there is an active bleeding, we have to consider vasopressin. Okay, because the vasopressin would make the vessels constricted, and thus the bleeding would stop. Okay. Of course, like if the bleeding was huge, we have to consider blood transfusion, and because of the blood transfusion, we have to consider in the first place we have to do what type of investigations for the patient. No. So before transfusing, what do we have to ensure? Exactly. So we have to check the blood group, and this is what we call the cross match. Okay. All right. And also, like if the bleeding did not stop, so we have to do endoscopy. So the evaluation or the investigation would be through endoscopy, and the endoscopy could be also therapeutic by either vasopressin injection or like the fibrin clots. Okay. Surgery is really indicated because, as we said, like only 10% of cases will lead to bleeding. So the next cause is the Dwalafoy's lesion. So this is a congenital vascular malformation, but it's an arterial malformation. Okay. And it's basically it's a tortuous visible artery that's a submucosa. Okay, and it protrudings to the stomach mucosa. Okay, so how is it going to bleed? Exactly. So it will be a direct erosion to that vessel, which cause the bleeding. So it's not associated with an ulcer or inflammation, as the case of the peptic ulcer disease. Okay. The lesion would be an erosion to the gastric mucosa into a large submucosal or mucosal vessel, and it's located also in the lesser curvature. And since it's located in the lesser curvature, it will be associated with a massive bleeding. And since it's congenital, there is no risk factor for such lesion. So this is the endoscopic appearance of the Dwalafoy's lesion. And this is the oozing of blood from an active bleeder. Okay. So this is what they call oozing. Usually, like if there is an active bleed, we can determine where is the site of the erosive or erosion to the mucosa. Okay, and as a result, we can stop this bleeding. However, if we do endoscopy and the bleeding would stop, we cannot determine exactly where's the site of the Dwalafoy's lesion. So how do they present? It's an painless upper GI bleeding. So painless hematemesis or melena, and usually it's diagnosed in the like mid-age, not the elderly, and it's
Mm-hmm.
2:1 male to female ratio. As we said, it's not associated with ulcers. The bleeding would be massive, voluminous, and however, it can stop spontaneously. And why is that? Because since it's in the lesser curvature, so it would be like branches of the left gastric artery, okay? And since we're talking about larger arteries, so they can heal and stop the bleeding quickly because they have a muscular wall, okay? So these muscles can contract and stop the bleeder. As we said, the endoscopic diagnosis would be difficult because if you do endoscopy while the bleeding has stopped, you cannot determine exactly where's the site of the bleeding. And the recurrent injuries is also common. So, what's the management of such cases? Endoscopy would not be effective, as we said, because it would be difficult to decide. And if there would be like recurrent bleeding, then we have to consider surgery. And usually it's called wedge resection. So like we cut the whole wall of the stomach and then we suture the stomach again in order to remove that vessel. So next is the aortoduodenal fistula. So you have to remember it's associated with two main things: the synthetic grafts of the aorta, okay, and the aortic aneurysms. All right. So or it could be also as a result of inflammation to the duodenum, because as we said in previous lectures, with any inflammation, we have to consider the complications of fistula formation or perforation. Okay. And what's fistula? Yes, so connection between two hollow organs. So in this case, it would be the aorta and the duodenum. Okay. So the causes would be infectious aortitis or aortic aneurysm. The second, which is the more common, it's associated with the graft. So if the graft is inflamed, then it can create fistulas. Okay. And it's characterized by something they call it a herald bleeding, and it's followed by inevitable bleeding. So usually these kind of patients would die because of these bleeding. Okay, because especially like if it's associated with the graft inflammation of the aorta, then the repair would be very difficult. Okay. So the diagnosis and surgery of such cases is not important, but remember, why is it happening? Okay. Next is the angiodysplasia. So when we say angiodysplasia, what kind of patient population you would consider? It would be elderly and especially it's associated with chronic renal disease, okay, or aortic stenosis. So angiodysplasia is the like a weakness in the vessels, okay, and they especially happen in the like aortic stenosis and renal failure patients. It's kind of like arteriovascular malformations, and this time it's in the veins, not in the arteries, as in a dual foil lesion. Okay. The pathophysiology is not important in this lecture. Yes, the esophageal sources of the angiodysplasia account for less than 3% of patients with upper GI bleeding, so it's very rare. these are other causes. So infectious esophagitis, GERD, Barrett's esophagus, they all can lead to upper GI bleeding. Okay. And other reasons like esophageal malignancies and Crohn's. For the infectious esophagitis, you just have to know that the vulnerable patients would be the immunocompromised, and most commonly it's going to be associated with CMV esophagitis, herpes simplex virus esophagitis, or candida infection as well. Okay. Next is hemophilia. So as we said from the name, it's blood in the biliary tree. Okay. And one thing you have to consider, why is there like blood in the biliary tree? So someone said trauma, right? So the trauma, where is it coming from?
What causes the trauma?
Yes.
Or car crash? Car crash? Any other one?
Surgery. So like with any surgical intervention to the biliary tree, which is the most common cause, would be the ERCP. Okay. And what's ERCP? So ERCP stands for endoscopic retrograde cholangiopancreatography. So they go with the endoscopy, and then through the ampulla of Vater, they get into the biliary tree in order to see if there is any lesion in the biliary tree or the pancreatic duct. Sure.
So